everyone, and welcome to another episode of The Doc is In. I'm Eugene Achi. I'm an epileptologist at the Cleveland Clinic, Abu Dhabi, and I have the pleasure of speaking to one of my colleagues today, Dr. Ayman Haykal, who is also an epileptologist in our department and has spearheaded our stereo EEG program since he has joined us. Now, Dr. Ayman and I share a special bond. We both trained in the same institute, and so we have the same alma mater, and for that we have a special connection. So welcome, Dr. Ayman. Thanks for joining us.
Thank you, Dr. Eugene, for the introduction.
Very good. So I have an exciting topic for today. We're going to talk about neuromodulation and epilepsy. Now, as you know, when we discuss neuromodulation, we're discussing specific ways of modulating or changing the brain activity through either an electrical current or a magnetic current. Today we're going to focus on an electric current, and the way this works is essentially we are trying to change the inherent activity found in the cells, the electric activity, so that it's not very elevated like in the case of epilepsy. And we do that through different devices. So that's why you're here. Help us out. What devices do we have out there for neuromodulation?
So as you mentioned, neuromodulation, basically the idea is that you send electric pulses to the brain to modify the behavior of parts of the brain that generate seizures. So it's used to treat patients with epilepsy who do not respond to medical treatment, who do not respond to medications. The idea is that you implant devices that send electric pulses to the brain, either directly within the brain or indirectly through a nerve in the neck called the vagus nerve. So we have 3 devices currently available for neuromodulation. Okay, the oldest one, the one that we've had for a while, since the late 1990s, is the vagus nerve stimulator. So vagus nerve stimulator is a device that is implanted in the upper chest under the clavicle on the left, and the device is connected to wires that go to the neck, to a nerve in the neck called the vagus nerve. And the idea is that the device sends electric pulses to the vagus nerve. Vagus nerve, of course, is connected to the brain. So what you're doing is you're indirectly sending electric pulses to the brain through that nerve in the neck.
Absolutely.
Right? So it is not brain surgery. The surgery is done in the upper chest, and the wires that send the electric pulses are basically in the neck. Mm-hmm. So this is the first device. It's called vagus nerve stimulator, or VNS. The second device is called the deep brain stimulator, or DBS. Now, this has been around for a while. In the beginning, it was used for Parkinson's disease, but then it was found out that you can use a different target in the brain to help reduce seizures. So the idea is that you also have a device implanted in the chest, in the upper chest. But in this device, unlike the vagus nerve stimulator, the stimulation happens inside the brain. So the device is connected to wires that go into a deep part of the brain called the thalamus. And we implant usually 2 wires, right and left. And you send electric pulses regularly through the device to that deep part of the brain. The third device is called a responsive neurostimulator. This has been around for maybe 10 years or a bit more. In this device, this is also in a way deep brain stimulation. You have an electrode in the brain, usually in the part of the brain where the seizure is happening, where the seizures are coming from. The device is implanted on the inside of the skull. So it's not here in the upper chest, and it's connected to wires that go to the part of the brain where seizures are starting. And the device basically gives electric pulses to abort seizures. And this particular device has an additional function. It can actually detect seizures. And when it when it identifies the seizure, same electrode that is implanted can identify a seizure and can respond to a seizure with an electric pulse basically to abort the seizure. So that's why it's called responsive neurostimulation, because it responds to the seizure recordings.
That is wonderful, an amazing technology. We're going to delve a little deeper into each one of those, and I know that was a lot of information for our listeners. So let's start with the oldest one, approved in 1997, the vagal nerve stimulator, and that has come through multiple iterations and generations. So I've had patients come to me and they've just found out about this and they say, "Doc, I want this." So they're usually still struggling with seizures. They're trying to find a solution. Can you walk me about that? Can you walk me through the discussion you might have with the patient about when to get this device, what to do first before deciding on a device like this, and what they should expect if they were to get a device like this?
Okay. So these devices, all of these devices are considered in patients who have drug-resistant epilepsy or medication-resistant epilepsy. That means we have...
Yes, could you please tell me how do you define that?
Yep. So in general, about 2/3 of patients with epilepsy respond to medication. That means you give them medication, the medication works, it stops seizures, they become seizure-free. And usually these patients do not need anything else but the medication. Okay. Unfortunately, in roughly 30% or 35% of people, seizures continue despite medication. So if a patient tries one medication and seizures continue, and then we add or switch to a second medication and seizures continue, then we conclude usually, it doesn't mean we stop trying with medications, but at this point we know that the chances of responding to treatment, to responding to additional medications is slim. And at that point we start thinking about other treatment options.
Got it.
Now, if the
so
patient...
broadly speaking, if they've tried 2 medications at good enough doses, they continue to have seizures, they already fit the definition of medication-resistant epilepsy or drug-resistant epilepsy.
Exactly. And this is when the patient should undergo additional evaluation to know what type of seizures they have, where the seizures are coming from in the brain, and then determine what other treatment options are available. Now, in general, the first treatment option we think of, if a patient has focal epilepsy, that's epilepsy that is coming from a particular spot in the brain, what we always prefer, if medications don't work, is epilepsy surgery. That means trying to find out where exactly seizures are coming from, and then doing surgical resection, which is removing the seizure focus in the brain, removing the part of the brain that is generating seizures.
And that is because it could be curative, right?
Exactly, because that has highest chances of achieving seizure freedom, of stopping seizures completely. And when this is successful, actually some patients are able to, after a while, stop taking medications and remain seizure free.
Great. So the most important thing to stress to the patient here is that they need to undergo an evaluation, whether with a scalp, prolonged EEG to capture their seizures, a PET scan, MRI, other modalities we use to better define or classify their type of epilepsy. So when and what scenarios then do you consider a vagal nerve stimulator?
Right. So unfortunately, epilepsy surgery, so again, the first thing I would think of if a patient does not respond to medications, the first thing we should try to do, if possible, is epilepsy surgery. But unfortunately, this is not always possible. So sometimes the epilepsy is generalized, not focal. So it's not coming from one particular spot in the brain. The seizures are starting on both sides of the brain in a large area, and these patients are not candidates for epilepsy surgery at all. In some patients also, the seizures might be coming from more than one spot. They might be coming from, a spot on the right and another on the left. And in these cases also, most of the time, we cannot perform epilepsy surgery. There are cases also where we do our best to localize the seizure focus to figure out where the seizures are coming from, and we cannot accurately do so. And finally, there are cases where we know exactly where the seizures are coming from, but we cannot do surgery in that location in the brain because it has important brain function. For example, we cannot do surgery in the part of the brain responsible for speech because that will cause speech impairment. We cannot do it in the part of the brain responsible for movement because that can cause weakness, etc. So in certain scenarios, surgery is not possible. This is when I would consider other treatment options, with specifically neuromodulation. That can be VNS, DBS, or RNS. So VNS is probably the least invasive in a way because it does not, you're talking about surgery completely outside the brain, right? You're not implanting the electrodes in the brain. So one advantage of VNS is that it's less invasive and it works for most seizure types. It does not require knowing exactly where the seizures are coming from. For example, with RNS, you need to have a lot of testing to figure out the exact focus, the exact location of the seizure focus in the brain, because this is where you're going to implant the device, where you're going to implant the wires. This is not required in VNS. So in a way, VNS is less invasive and widely available and more accessible, if you may, treatment.
Absolutely. And when I explain different modalities to patients, automatically they tend to favor VNS because it's an hour to 2 hour surgery. It's a 1-day surgery. They get to go home. And then the titration is very easily achieved nowadays with the newer devices. Okay. They also, I tend to explain to them that the vagus nerve is such a huge nerve and the majority of the fibers are going towards the brain. So it acts like a highway where you can deliver electricity, so to speak,
That's
from
absolutely
outside.
true.
And they like that idea without having an invasive brain surgery. Well, that's great. So DBS is another treatment. Obviously you mentioned DBS was approved many years ago in the late 90s for essential tremor, Parkinsonism, and since then there have been other indications. Why the anterior nucleus? What's its role in the temporal lobe seizures and the limbic system? And how good is this device?
So in deep brain stimulation in DBS, the wires are implanted in a part of the brain called the thalamus, right? The thalamus, think of it as a hub that is connected to the outer. The thalamus resides in a deep part of the brain, right? And it's present on right and left. And it is connected to the outer layer of the brain called the cortex, where seizures come from. But we know that the thalamus is involved in the organization of abnormal electric activity that causes the seizure. So there are a lot of different mechanisms by which sending electric pulses through the thalamus can reduce seizure activity. And within the thalamus is a small structure, but it has a lot of different compartments or different, we call them nuclei. One of them is called the anterior nucleus of the thalamus. Stimulation of this part seems to be very helpful in patients who have temporal lobe epilepsy, especially epilepsy coming from the deep part of the temporal lobe or frontal lobe epilepsy. And this is because this part of the thalamus has very good connectivity to these parts of the brain, right? So initially when DPS was approved, that was the target for stimulation. But then with time, because it was noticed that patients with temporal lobe epilepsy and frontal lobe epilepsy have best benefit from DBS, then doctors started exploring other targets within the thalamus.
Absolutely,
So another
yeah.
target is the centromedian nucleus of the thalamus, another part of that hub in the brain, and that has more connections to other parts of the brain, especially the outer part of the frontal lobe, outer part of the temporal lobe, right? So that became more recently a target for stimulation as well. It's the same idea. So you're implanting two wires, right and left, in the thalamus, but within the thalamus, you might choose a different target. You might refine the placement of that electrode based on where the seizures are coming from.
It's very exciting, and very, very soon, hopefully, we can pick which seizure type is better served by implantation of which thalamic nuclei. I I have a tough time sometimes explaining this to the patient, so I've come up with sort of I'm sure it's been done before, but the thalamus, to me, being a relay center, it sends everything from the brain to the body and vice versa, is like the electric company. They decide where should the electricity go to what area of town. And so when I explain that to the patient, and I explain that there's a strong connection between the generators of electricity, which is the covering of the brain, and where it goes next through that thalamocortical pathway, we can alter that connection, and we can break it and short circuit it, you know. And so
That makes sense.
that helps a little bit explain why this should help with seizures, and when we know full well that most seizures are generated in the outer layer in the cortex, but they do tend to go through that relay pathway. So it's very interesting, and I'm so excited about where this goes in the future. Okay, let's switch gears and talk about something a little more complex and maybe a little more smart as a device. This is a closed loop system, as you mentioned, the RNS. You've had a lot of experience with RNS. You have several patients with an RNS. Can you tell me why this device is different, and what you can do in the office or sometimes even online through accessing the patient's data to improve the seizure control with this device?
So you mentioned the term closed loop system. A closed loop means that the device is used to both record seizures and then so basically gather information from inside the brain, and then react to this information with electric stimulation. So that's why it's called the closed loop system. So the first two devices we talked about, VNS and DBS, basically they only send those electric pulses to the brain. In the case of VNS, to the vagus nerve, and in the case of DBS, like we mentioned, to the thalamus, that deep relay center or hub in the brain. With responsive neurostimulation, the same electrode or wire that is implanted in the brain is used to record seizures. It's implanted in the part of the brain where seizures are coming from. So it records seizures. It is trained to identify a seizure and react to the seizure with electric stimulation.
Absolutely.
Right? So
and you can refine that training. I
exactly.
Understand. Yes.
So what happens is the patient can sync the device, can interrogate the device at home, and then upload information to a computer. So basically, you download the seizure recordings from the brain,
from the server,
and then the physician would review the seizure recordings and refine, adjust the settings, program the device. So basically, you program the device as follows. You say, like, when you see this discharge, or when you record this, react with an electric pulse that has a certain intensity, and then you can adjust that, right, for a certain duration, etc. So another thing that is unique about RNS is because you're recording from the brain, then this can offer give us valuable information.
Absolutely, very
For
valuable.
example, we can figure out how often seizures are happening, see how the patient is responding to treatment, because we are recording from within the brain. That's like in a way a window into the brain, and gives a lot of useful information about seizures, how frequent they are, how a patient responds to adjustment of the device. After each change in settings, we can see, based on recorded seizures, whether there was a response or not. We can actually see if a patient responds well to a medication, just from these seizure recordings. So that's one thing that is unique about RNS.
That is so advantageous, especially when you have some patients that don't have an aura, don't know they're having a seizure, or have some memory problems and have a difficulty telling you how many seizures they've had. So that is very advantageous. Very good. So how often do you tend to see your patients once they're implanted? Can you give us a broad idea about what's expected for the patient once they receive VNS, DBS, RNS? What do they do next? And how long does their battery life last? And what do they need to do in the future with the device implanted in their body?
So all these devices, when they're implanted, so a patient would undergo surgery to implant the device, right? In the beginning, the device is not turned on, and so it's kept off. And then there is a clinic visit after implantation, after the surgery, where we start programming the device. So we turn it on, and the rule for all these devices is you start with a low signal. You start with a low intensity electric pulse, and this is to reduce side effects. So you start low and then you increase slowly, right? So in the beginning, appointments are frequent because you're trying to increase to get to a dose that works. So you're increasing the setting gradually each visit. So for example, in the beginning with VNS, it's every week, couple of weeks in the beginning, and then as you start seeing a response, and after you get to a certain intensity of that electric current, then you can space the visits out, right? But you start doing it every few weeks, and then every few months, etc. And that applies to all devices. It's a gradual process.
Great. In summary, what's expected is a visit every 2 weeks to a month, depending on a device. And once we reach a certain current, then it's more every 3 to 6 months to check on the battery, etc.
And of course, that varies from one patient to another, right? Depending on how frequent the seizures are, depending on how they respond to the treatment. If seizures decrease significantly, patient is stable, then you space out these visits, right? And then the visits are less frequent.
So I know that depending on the stimulation parameters, how frequent they are, how high the stimulation is, the battery life can change. For instance, for the vagal nerve stimulator, I may tell the patient we may need to change it in 5 to 8 years. With your patients that have deep brain stimulation and an RNS, what expectations do they have for battery life?
I think it's quite similar. It really depends on the stimulation settings and on the particular patient. Some patients respond to a low current, right? And then in that case, you're consuming the battery much slower, so the battery life is longer. Right. In some patients, you have to go up to high intensity settings. Right. You keep upping it to get a response, and then you can also adjust the frequency of stimulation, how often the device is sending those electric pulses. In that case, you burn more battery, and you have to replace a bit earlier. Right?
That being said, it's not a very complicated procedure, I would add to our audience. These.
Correct. Yeah, replacing the battery is much easier than the original surgery, right? So, for example, in the case of VNS, you're just swapping what we call the pulse generator, which is the device that generates the electric pulses. But the wires you don't have to revise. Yeah, they stay there from the original surgery. So it's a straightforward procedure.
Okay, let's walk things back a bit. So let's say we have a patient that is drug resistant and has undergone the initial workup for epilepsy surgery, was found to have multifocal epilepsy, and we decide that neurostimulation or neuromodulation is the next best avenue. I've had patients or parents tell me, I want this and I want to stop medication. How do you counsel the patient and their families about what's expected from these neuromodulation devices and what to expect with regard to medications?
Now, if a patient with drug-resistant epilepsy is not a candidate for epilepsy surgery, and we're thinking about neuromodulation, DBS, VNS, or RNS, these devices can reduce seizures, and they can reduce them significantly. So, roughly for most patients in the first couple of years, you might expect at least or around 50% seizure reduction. But for all these devices, research and clinical experience show that with time you have better results. So the seizures decrease gradually over time. So on the long run, you might have reduction in seizures of about 70%. In some patients, it could be more. Now,
That's great.
some patients might become seizure-free, but unfortunately, that percentage of patients is low. So only a minority of patients might become seizure-free. In general, these neuromodulation treatments do not achieve complete seizure freedom in general. And therefore, unfortunately, we still need the medication. So having VNS or DBS or RNS does not mean that the patient can stop medications completely. However, a lot of our patients with drug-resistant epilepsy take multiple medications. And in a lot of cases, after we see significant improvement with VNS, DBS, or RNS, then we might be able to reduce the medication burden. We can reduce the doses of medications or number of medications they're on. So medication reduction is possible when there's a good response to these treatments. However, stopping the medicine completely is not possible.
Yes, absolutely. And you brought up a really good point about not just seizure control, but improving the quality of life. Some of these patients, like with Lennox-Gastaut syndrome, taking 4 or 5 drugs will have significant side effects. And so beyond improving seizure control, these devices can help by reducing seizure frequency, reduce side effect of medications. But yeah, I really stress to the family that we're not touching the medicine initially, especially during the titration phase.
Right.
And then when we reach a good seizure control, we can start discussing reducing medications. And it's really interesting how these medicines how these devices continue to show better and better response over time. Some thoughts about neuroplasticity there, which is the change in the way the brain adapts over time. So, well, we've talked about a lot of things today. We've maybe too much, but I want to just maybe summarize things. If you are a patient with epilepsy and you have drug-resistant epilepsy, which I may remind you is failure to control your epilepsy with 2 or more medications, then please come see us, come see an epileptologist here at the Cleveland Clinic, Abu Dhabi, because you will be worked up in great detail and to see if you're a candidate for epilepsy surgery, and possibly these neuromodulation techniques that we've discussed at length today. In any case, if you have any questions about these and are interested in them, please do come see us. Dr. Ayman, I want to thank you for your time and your expertise. You've been a pleasure to talk to. So thanks a lot
Thank
for.
you very much, Dr. Eugene. This was an excellent discussion, and it's a pleasure to be on this podcast.
Thank you very much. And with that, I bid you adieu until next time.